Welcome to our video on seronegative spondyloarthropathies. The seronegative spondyloarthropathies are commonly remembered using the mnemonic PAIR, P-A-I-R. P is for psoriatic arthritis. A is for ankylosing spondylitis. I is for inflammatory bowel disease. And R is for reactive arthritis. So in this lecture, we'll be focusing on psoriatic arthritis, ankylosing spondylitis, and reactive arthritis. There will be an entire lecture in the GI section dedicated to inflammatory bowel disease, so we won't go into that here. Now, suffice it to say that inflammatory bowel disease can be associated with joint pain, and treatment should focus on the disease process itself and not the joint pain. Now, the one high-yield point that we will mention about this condition is this. Since NSAIDs can make the diarrhea of inflammatory bowel disease worse, be on the lookout for a patient who is taking lots of NSAIDs to treat joint pain and then develops significant diarrhea as a result. As we just illustrated, this lecture will cover these three conditions. And for each condition, we'll be discussing definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's start with the definition of psoriatic arthritis. Psoriatic arthritis is an inflammatory musculoskeletal disease that primarily involves the nails and joints. Its name arises from the fact that it is commonly seen in patients who have already been suffering for psoriasis for a period of time. And as with many disease processes, the etiology of psoriatic arthritis is not well defined. The first two risk factors listed on this slide are common to each of the diseases covered in this lecture. Patients tend to be positive for the genetic marker human leukocyte antigen B27, which is often abbreviated as HLA-B27. Additionally, rheumatoid factor will be negative. And this is what gives this group of diseases the name of seronegative spondyloarthropathies. Psoriasis is another risk factor for this. Those patients that have already developed skin disease findings, such as a silvery scale over an erythematous region on the elbow, may be even more susceptible to arthritic changes. As is the case with other causes of inflammatory arthritis, the arthritic pain in these patients tends to be worse in the morning. To help distinguish psoriatic arthritis from rheumatoid arthritis, look for DIP involvement in the hands. This is an important distinction because arthritis may precede skin lesions in a minority of these patients. So, in other words, it might not be obvious when this patient first presents to you that this is a psoriatic arthritis and not rheumatoid. So again, look at DIP involvement. Now, patients may also have severe inflammation at the finger joints, termed dactylitis. And that results in a swollen sausage appearance or severe inflammation and pain at tendon insertion points, termed enthesitis. Perhaps the most important tip-off for this disease would be nail changes, such as pitting, which are small divots in the nail, or onycholysis, where the nail detaches from the nail bed. The latter of these will be illustrated on the next slide. As mentioned before, psoriatic skin lesions would be another way that this disease may present clinically. Here we have an image of severe psoriatic arthritis. Notice the prominent detachment of the nail from the nail bed, even to the point of the nail being lost on the big toes. This is termed onycholysis, and it's also seen in fungal infections. Finally, notice the swelling of the distal part of the left second toe, which appears to be a sausage digit. To help remember the association of these findings with psoriatic arthritis, you may think of this as psoriasis of the nails, since the nails appear to be crumbling and scaling like the skin of a psoriasis patient. Here we see a series of MRI images in the sagittal plane in a patient with psoriatic arthritis, and they're consistent with enthesitis. As far as orientation is concerned, we can appreciate the tibia coming in contact with the talus in the more anterior part of the image. And then we can see the Achilles tendon connecting to the calcaneus in the more posterior part of the image. Okay, so in this far left image, we can appreciate areas of high signal intensity indicating that inflammation is present. The large arrow in the back is pointing out the area of enthesitis, where inflammation is occurring directly at the Achilles tendon insertion site. The arrow at the joint space between the tibia and the talus is an area of synovial fluid inflammation, or synovitis. Images B and C show the insertion site of the Achilles tendon before and after contrast was administered. The hyperintense area confirms a region of significant inflammation, and there are small areas of bone erosion below this. Enthesitis is common to each of these seronegative spondyloarthropathies and should be classically associated with them in your head. So when you think of enthesitis, think of seronegative spondyloarthropathies, and vice versa. Now, the diagnosis of psoriatic arthritis can be made based on the clinical presentation just described. Were you to perform an X-ray, you may see a pencil-in-cup deformity, which we'll illustrate with other common X-ray findings on the next slide. Finally, enthesitis is a clinical finding that can be appreciated on MRI, as shown on our prior slide. Or you can see it on ultrasound. And recall that this finding is not only seen in psoriatic arthritis, but also in ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. Again, all of these seronegative conditions. Here we have an X-ray image of the hands of a patient with psoriatic arthritis. First, notice the joint deformity present at the distal interphalangeal joints in the second and third digits. Also notice the characteristic pencil-in-cup deformity seen in the distal interphalangeal joint of the thumb. As far as treatment goes, there are non-pharmacologic and pharmacologic methods that can be employed, often in conjunction with one another. Exercise, physical therapy, and weight reduction can each help these patients. Now, as far as drug therapy goes, mild cases are generally managed with NSAIDs. More severe cases may require a stronger drug, such as a non-biologic disease-modifying anti-rheumatic drug, like methotrexate, or a biologic DMARD, and that includes things like anti-TNF-alpha agents, such as etanercept or infliximab, and IL-17 inhibitors, for example, secukinumab. Now, biologic drugs are so named because they use some component of living organisms. In many cases, biologics act like natural proteins that target cytokines, such as IL-17 and TNF-alpha, and cell surface proteins like the IL-1 receptor. Non-biologic drugs are engineered without parts of living organisms and tend to target inflammatory pathways. As an example of this is methotrexate, causing increased adenosine concentrations outside the cell, a molecule which has anti-inflammatory properties. Which three clinical features of psoriatic arthritis help distinguish it from rheumatoid arthritis? Okay, the three clinical features seen in psoriatic arthritis, but not rheumatoid arthritis, are psoriatic skin lesions, nail pitting, and involvement of the distal interphalangeal joints. Again, rheumatoid arthritis is notorious for affecting all small joints of the hand except the DIPs. We will now discuss ankylosing spondylitis, which is a board favorite. Ankylosing spondylitis is a chronic inflammatory arthritis of the spine and pelvis. As the disease progresses, there is the potential for fusion of the involved joints. While the exact pathophysiology of ankylosing spondylitis is beyond the scope of Step 2, it's important to know that TNF-alpha and IL-17 are two of the major inflammatory mediators that propel the disease process forward. The reason this is crucial to understand is that we have medications that can specifically target these. Ankylosing spondylitis is far more common in males, particularly those younger than 40. A positive family history makes the disease more likely. And this makes sense given that HLA-B27 is a genetic marker inside the body that tends to be positive in each of these seronegative spondyloarthropathies. Finally, rheumatoid factor, of course, should be negative, because this is a seronegative condition. In a test, the vignette often describes a young male who presents with chronic progressive lower back and/or buttock pain and stiffness that improves while moving, or when NSAIDs are taken. Remember, the disease process of ankylosing spondylitis is the result of chronic inflammation. Widespread inflammation gives degenerative changes that create a stiff and immobile spine with reduced lumbar flexion. And this inflammation also leads to chronic activation of osteoclasts, which consume bone. Anytime osteoclasts are significantly outperforming osteoblasts, then osteoporosis can result. Osteoporosis, in combination with a stiff spine, makes these patients especially prone to vertebral fractures. Perhaps just as important as recognizing the way this disease affects the spine is knowing the extra-articular manifestations that can arise in these patients. And we'll cover those now. Let's start by highlighting the 3 A's of ankylosing spondylitis. These are anterior uveitis, AV heart block, and aortic regurgitation. Anterior uveitis is the most common presentation outside of joint pain for these patients, and we'll illustrate that on the next slide. Recall that atrioventricular heart block is when the electrical transmission from the atria to the ventricles is impaired. Aortic regurgitation, which is also termed aortic insufficiency, manifests as an early diastolic murmur best heard over the third intercostal space, with an elevated pulse pressure. Here we see a picture of anterior uveitis. In this condition, the middle layer of the eye, including the iris, becomes inflamed. Some of the typical findings of this condition are visualized here. The eye is diffusely red. There is ciliary flush, where the conjunctival vessels become engorged and give a ragged red appearance, especially at the edge of the cornea. And the pupil is irregularly shaped, though it's often constricted instead. But here you can at least appreciate that it's not round. Now, clinically, this patient will often experience severe pain, photophobia, light sensitivity, and diminished visual acuity. Now let's round out those extra-articular manifestations. Because of the stiffened spine and altered posture, the chest can't expand properly. It's not uncommon to also see enthesitis in these patients. Now, enthesitis was illustrated earlier and is most common at the ankle and the shoulder. With time, this chronic inflammation can lead to calcification at these sites. To help make the association between enthesitis and the diseases covered in this lecture, you might remember that ankylosing spondylitis can cause pain at the ankle. How might the FEV1 to FVC ratio be affected in a patient with ankylosing spondylitis? To answer this question correctly, we should first consider whether ankylosing spondylitis is an example of a restrictive lung disease or an obstructive lung disease. In patients with ankylosing spondylitis, the spine is stiffened and the patient's posture is altered. And as a result, the chest can't expand properly, like we mentioned on the previous slide. Now, there's no obstruction to the outflow of air, but rather the chest wall is restricted in its ability to move air in. Thus, ankylosing spondylitis is an example of a restrictive lung disease. Okay, knowing this, let's review the concepts of FEV1 and FVC. You might recall from our Step 1 review content on pulmonology that the FEV1 is essentially how much air a patient can exhale in 1 second following maximal inhalation. The forced vital capacity, or FVC, is the total amount of air that can be exhaled after maximal inspiration, and it does not include the air left in the lungs after maximal expiration, which would be the residual volume. In restrictive pathologies, the ability to fully inhale is compromised. As a consequence, there is less total air available to be exhaled. This means less air expired over the first second, and less total air movement. And because the FVC tends to be decreased more significantly, the ratio of the two is usually going to be greater than 80%. Now, since 70% would be a normal FEV1 to FVC ratio, the ratio has been increased, making that the correct answer. Now, if you need to review this concept further, you can visit Section 2 of Pulmonology from our Step 1 library. The most important step for diagnosing ankylosing spondylitis is to obtain an X-ray of the lumbar and sacroiliac region. Question stems may try to bait you into getting an HLA-B27 test, but that's actually not a diagnostic test. And they may also have you go searching for an elevated ESR, which is also nonspecific. Now, an MRI can be obtained, but only in cases where the X-ray was negative, such as early in the course of the disease, and yet the clinical suspicion of the patient having this disease remains high. Let's take a look at a couple of X-rays, since this is such an important point in diagnosing this disease. So here's an X-ray showing sacroiliitis, a diagnostic finding in ankylosing spondylitis. Hopefully you can appreciate the sclerotic changes at the SI joint, and they're especially prominent on the left side of this image, so the patient's right. Here we see a radiograph of the characteristic bamboo spine that can be seen in patients with ankylosing spondylitis. And this tends to be seen later in the course of the disease and occurs when the joints of the spine fuse together and the intervertebral discs become ossified, giving the spine a bamboo-like appearance. Now, it's crucial that you recall that obtaining an X-ray is an important first diagnostic step for a patient presumed to have this condition. On to treatment. As with psoriatic arthritis, this involves NSAIDs like ibuprofen or naproxen as first-line treatment. COX-2 inhibitors, such as celecoxib, are also considered first-line. Now, when this is no longer effective, anti-TNF-alpha drugs, such as etanercept and infliximab, or IL-17 inhibitors like secukinumab can actually be prescribed. Recall that these drugs are examples of biologic DMARDs. Physical therapy can also prove useful, particularly when aimed at improving extension of the spine. And that's pretty logical. Their spine is fusing up. You want them to maintain that mobility. Now, as one final important point, because these patients are so prone to vertebral fractures, all ankylosing spondylitis patients with neck or back pain who arrive in the ED are immobilized until imaging has been obtained, and a fracture or spinal cord injury is ruled out. We'll finish up by discussing reactive arthritis. Reactive arthritis is an asymmetric, inflammatory, post-infectious arthritis. Most commonly, it occurs within 1 to 4 weeks of a gastrointestinal or genitourinary infection, and we'll explain this definition further as we go along. Now, the pathophysiology of reactive arthritis is likely better understood than the previous conditions we've discussed. So when a patient experiences a GI or GU infection, lymphocytes are activated in an effort to combat the infecting organism. In certain high-risk patients, such as those displaying the risk factors described on the following slide, we'll show you what these are, these cells may migrate to the joints or a variety of extra-articular sites. And those sites include the eyes, the skin, mouth, or nails. So basically, you're starting with a GI or GU infection, lymphocytes get rolling, migrates to the joints, and then it migrates to anywhere else. The inflammation caused by the presence of these cells within these different bodily regions is what gives rise to the characteristic clinical presentation that students often remember with the phrase, can't see, can't pee, can't climb a tree. We'll expand on this concept further in our slide on the disease's clinical presentation. Now, those patients that develop reactive arthritis have usually had a recent GI or GU infection. And common bugs to consider include Campylobacter, Salmonella, Shigella, or Chlamydia. And young males are the most likely to develop this. And as with all of these diseases in this lecture, HLA-B27 predisposes to this condition, and rheumatoid factor is negative. The classic memory hook for reactive arthritis is that the patient can't see, can't pee, can't climb a tree, which helps recall the findings of conjunctivitis, urethritis, and arthritis. Now, conjunctivitis is also referred to as pink eye. The eye becomes a reddish pink color, itches, and it can be very painful. Urethritis is inflammation of the urethra and will show painful urination as the primary symptom. The arthritis of reactive arthritis is actually asymmetric. This means that it may affect one side of the body and not the other, most commonly involving the knee and sacroiliac joints. So let's turn to a pair of images to illustrate the possible skin lesions. Here we see an image of succinate balanitis, which is classically associated with reactive arthritis. Balanitis refers to inflammation of the glands of the penis. Now, in succinate balanitis, there are shallow, painless ulcers over the gland's penis and sometimes extending to the shaft. Now, this may be confused for herpes based on the appearance alone, but the penile lesions seen in patients with herpes are intensely painful. Here we see keratoderma blennoragicum, another dermatologic complication that can be seen in reactive arthritis patients. As the word keratoderma implies, there is keratinization or roughening and hyperproliferation of the skin. Now, the lesions are often pustular, resembling pustular psoriasis, with a yellow-brown color and waxy texture. Pay special attention to other clues in the clinical vignette that we're dealing with reactive arthritis, such as enthesitis or nail changes, since this can be confused with secondary syphilis. Now, for syphilis, the rash will be more maculopapular in appearance, as opposed to the pustular findings seen here, but it appears in similar regions of the body. Other clinical findings may include nail changes that resemble those of psoriatic arthritis, such as pitting and onycholysis, mouth ulcers, and enthesitis. Notice that enthesitis is common to each of the 3 seronegative spondyloarthropathies covered in this lecture. And you'll need to be attentive to the other clinical findings in order to distinguish between the 3. Reactive arthritis is diagnosed clinically when the described symptoms are present, particularly within a few weeks of a prior GI or GU infection. The stool and urine can be tested to help determine whether one of these predisposing infections is present or not. And given that the knee joint is commonly involved, synovial fluid can be sent to the lab to analyze for the presence of crystals or bacteria. Now, in the knee of a patient with reactive arthritis, there will be an elevated white blood cell count with sterile fluid, meaning no organisms are found on gram stain or culture. How can we differentiate a patient with reactive arthritis from a patient with arthritis caused by disseminated gonococcal infection? Okay, try to think of 2 or 3 distinguishing factors. The goal of this question is to help you think in broad differential diagnoses, recognizing that either of these diseases could appear in a question stem where risky sexual practices are mentioned. To distinguish the two, then, you could consider the timing of joint symptoms, the findings within the synovial fluid, and how sick the patient is. In the case of reactive arthritis, the infection comes weeks prior to the joint symptoms. In gonococcal arthritis, infection tends to coincide with the joint symptoms. If an arthrocentesis were performed, a patient with reactive arthritis would usually have a white blood cell count less than 50,000, and a patient with gonococcal arthritis would tend to have a white blood cell count above 50,000. Though this should not be used as a diagnostic tool in and of itself because of the high false negative rate. Now finally, patients with disseminated gonococcal disease are often much sicker and exhibit a fever and elevated white blood cell count. Now NSAIDs are first-line therapy for reactive arthritis. If the patient doesn't respond well to these, intra-articular glucocorticoids may be administered. Now it may be tempting to offer antibiotics to these patients. While certain circumstances may warrant this in treating the underlying infection, antibiotics won't resolve the joint symptoms associated with reactive arthritis. Okay, now let's wrap up with one board-style question. A 21-year-old male presents to his primary care physician with lower back pain for the past 4 months. He describes the pain as a dull ache and stiffness that improves throughout the course of the day. He says the pain is getting progressively worse and doesn't recall any inciting injury. He describes the pain as non-radiating, a 4 out of 10 in intensity, and has received some relief when taking NSAIDs. He denies recent weight changes or night sweats. He also denies any loss of sensation or muscle weakness. On physical examination, his temperature is 37.0 degrees Celsius, respiratory rate is 15 breaths per minute, heart rate is 80 per minute, and blood pressure is 124/79. There is mild difficulty with flexion of the lumbar spine. Tenderness to palpation is present in the lumbosacral region. Which of the following ECG findings is this patient most likely to develop? A. Peaked T waves. B. ST segment elevation. C. Prolonged PR interval. Or D. Absent P waves. Okay, now first of all, we need to be able to diagnose what this patient has. And there are many clues within the vignette to help with this. Notice that we have a young male with chronic lower back pain that improves throughout the course of the day. He experiences some relief when taking NSAIDs and denies any red flag symptoms such as weight change, night sweats, or loss of sensation. Finally, the physical exam is notable for tenderness to palpation over the lumbosacral region, or in other words, the sacroiliac joint. Given this clinical picture, the most likely diagnosis is ankylosing spondylitis. The question is focused on a possible complication of the presumed diagnosis. Remember that the 2 heart conditions most likely to develop in ankylosing spondylitis patients are aortic regurgitation and atrioventricular heart block. Recall those 3 A's of ankylosing spondylitis. And knowing this, C is the best answer, as a first-degree AV block is characterized by a prolonged PR interval. The PR interval is the time from the start of the P wave to the start of the QRS complex, and represents the time it takes for the electrical signal to conduct through the AV node. And a value greater than 0.2 seconds on an ECG would be considered abnormal. A is incorrect, since peaked T waves are an ECG finding in patients with hyperkalemia, which would be more associated with renal failure or drug toxicity. B is incorrect because ST segment elevation is a sign of myocardial ischemia for which this patient has no known risk factors. Finally, D is incorrect because absent P waves are classically associated with atrial fibrillation, which is not a common complication of ankylosing spondylitis. So again, C is the correct answer, and that concludes this section.